Hello, good morning. Last week we spoke about the new sepsis guidelines that have been delivered, and I've got a link below that'll make it easy for you to download those guidelines. Today we're going to talk about what those guidelines mean for us clinicians at the bedside. The guidelines don't attempt to help you make a diagnosis of infection, because that's quite complicated actually. Clinically, we potentially have two groups. One, patients are entirely well, we know they're not infected, and the other extreme, really sick. I've got low blood pressure, and the diagnosis of potential sepsis, septic shock is easier. But unfortunately, that's, life is not 0, 1, 1, 0 binary. There's a whole spectrum in between, and that's the difficulty. So the guidelines don't really go into discerning and differentiating that. The guidelines also stress that there's no explicit algorithms, but really more of a guideline. And they are put together by international level experts who have got a track record and experience of dealing with childhood illness, particularly sepsis and septic shock. So my plan today is to go through our guideline. Like I said, if you can download the PDF, that's probably the easiest. And on the fourth page, you'll see this protocol, which is what I want to talk about today. The misdiagnosis of sepsis can be really unforgiving. Delayed recognition means that the child's illness progresses, evolves, and can become life-threatening. Children do compensate in the early stages, but then they deteriorate quickly, and then often it's too late. So sepsis, there is a sense of urgency. It's important not to panic. A disciplined approach is needed, and on that basis, it's possible to reverse those issues. But acting early is very important. We shouldn't wait for certainty in this scenario, and if you are a junior clinician, get senior support at the earliest. The first principle is to, of course, start with the child. And sepsis, as I mentioned, isn't often diagnosed with certainty. The 2026 guidelines use certain criteria, certain definitions, and let's just go through those first. Firstly, sepsis is defined as an infection leading to life-threatening organ dysfunction, inclusive of patients with septic shock. And then a subset of this group is septic shock, which are those children who have cardiovascular dysfunction, and the dysfunction is not attributable to the cardiac or primary cause, such as related to heart. Probable sepsis is a clinical presentation consistent with sepsis, but infection is not yet confirmed. Suspected septic shock is shock of unconfirmed etiology, but suspected to be secondary to infection. And then there's septic shock with persistent hyperperfusion, which is sepsis with evidence of diminished perfusion of organs or the body despite the initial treatment. So the initial treatment, give the initial treatment, and then you say, okay, despite initial treatment, there's hyperperfusion. So this is a septic shock with persistent hyperperfusion. So by definition, septic shock, cardiac dysfunction is a problem with the heart, and problem with the heart is manifest normally initially in initial stages, seen as diminished perfusion. So that's on page 3 of the sepsis terminology. So that's the terminology we're going to be using from here on. So first of all, when you see the child, you have to ask, is the child sick? Is there likely to be infection? Is there organ dysfunction? Is there poor perfusion? So ideas of poor perfusion include lack of consciousness, tachycardia, which is out of keeping with the fever. So got the fever that causes tachycardia, but maybe the heart rate is much more. There's prolonged capillary refill, weak pulses, low blood pressure, oliguria, But of course, that's something maybe you need to ask the parents, because by the time when you're doing the initial assessment, you're not going to have an idea of that. Other ideas of decreased perfusion or issues is rising lactate and increased work of breathing. So if there is sort of an acidosis, a metabolic acidosis developing, then of course the child's going to breathe faster. So it's important to have that clarity in mindset when the patient comes in. And certain institutions like my own, we're using the Sepsis 6, and so if you suspect that infection is likelihood, there's a fever, there's tachycardia, etc., you institute a Sepsis 6. So now we have to decide, is this sepsis or shock? So as I mentioned, the idea of sepsis is that you have an idea, suspicion that infection is likely, and the patient's unwell. And the idea of septic shock, we've already described, is the low blood pressure, low perfusion indices. That gives you an idea of the shock side of things. So I'm just going to take you now through the algorithm. So if you can I can have a look at the screen, and as you do so, I'm going to have a look at this piece of paper. So you can see at the top, the quick guide has written these recommendations, strong recommendations, so that's good news. I mean, there's plenty of information in the literature say that this needs to be done. Conditional recommendations, less stronger. And good practice is, well, we think it's okay, but there's not enough evidence there, but we know it's good clinical practice. So if we go here, first thing, and this is actually quite a good thing in the guideline. They talk about a sepsis improvement program. So actually, they're asking hospitals, institutions dealing with children, to think about SOPs, standard operating procedures, for treatment of sepsis. And this is where sort of I alluded to the idea of the Sepsis 6. Every institution is going to have its own, and it's important to institute that as a first thing. Then you then demarcate it. Is it probable sepsis or suspected septic shock? Is it probable sepsis or suspected septic shock? So if it's just probable sepsis, you've got time to make that diagnosis. This is within 3 hours, and as soon as you've made that diagnosis, then you got to give antibiotics. That's important. So start empiric broad spectrum antibiotics. You allowed a time-limited course of 3 hours to make a diagnosis. The diagnostic evaluation supports the idea of a sepsis-associated organ dysfunction. So basically what it's saying is that there's going to be evidence of organ dysfunction as well. But there hasn't transferred to becoming a cardiac issue, an issue of perfusion. But if you see issue of perfusion, capillary refill is prolonged, then the thing is this is suspected septic shock. That puts the scenario, if you can see here, the double arrow, so a strong recommendation to within a maximum 1 hour recognition of sepsis, you should have given antibiotics. So that's that. So basically early antibiotics, and you've got 2 groups. So now we move along and see the next group, the next phase. Now, it can be done in tandem and requires continuous reassessment. Previous protocols and work in literature has always been talking about goal-directed therapy, where you give a medicine, you give a fluid, and then you see the impact. So there's 2 things. First of all, does the patient require a fluid bolus? Well, if the patient is tachycardic and is likely to shock, then of course the likelihood of a bolus requirement is there. And you also may need to consider a vasoactive medication. It used to be you used to think it in tandem: give fluids, then start the vasoactive medication, which is specifically inotropes. Well, actually, they're saying now, well, you can start them hand in hand as well, which is really good news and interesting, because it means also if you start the medicines early, you minimise the issue of overloading the patient with fluid. And what's important about this guide is also it mentions the idea of a patient. What's good about this guide? It also mentions the idea of its institution, a place of work with or without an ICU. If you have an ICU in the building, children's ICU, you can be a bit more not gung-ho, I wouldn't say gung-ho, but at least you can encourage the use of fluids to a higher level. So 10 to 20 mils per kilo bolus is usually given, and you see the effect of that bolus. And it's balanced, so you need to have a look and see, you give the volume and see how it's going. And in an institution without an ICU, you can give up to 40 mils per kilo of volume over a period. But those institutions with an ICU, you can give 40 to 60 mils per kilo of volume. Now, what's changed is now we're going towards the idea of not using normal saline as that bolus, because we're seeing lots of patients developing a acidosis due to the hypercholemia aspect of the saline. So now we've gone away from that and using buffered crystalloid. So in your institution, have a look and see what you have. But Ringer's lactate is an example of that. And the lactate in the Ringer's lactate is not the same lactate we're talking about. That's the Ringer's lactate associated with bicarbonate. So in terms of the vasoactive medication, you start and titrate is epinephrine or norepi, and it depends really whether you think it's you need to just have pure vasoconstriction or vasoconstriction, and you need the effects, the inotropy effects, the positive cardiac effects of the inotropes. And it's possible to initiate these peripherally through a good venous access. The bigger the bore, the cannula, the better. Nearer to the heart, the better. And if you're using this route, it's always desirable to dilute the inotrope by at least 10 times to avoid major constriction, especially if you have a whole load of volume that's dumped into a vein that suddenly stops working, and there's a whole load of inotrope there that could cause issues. So rather than that, you need to make sure we have good access. And it emphasises this can be done alongside the fluid therapy. Now, there's a red box there basically saying, be a little bit careful, you don't need to give fluid volume if things are resolved, perfusion is resolved, there's fluid overload, or the septic shock without hyperperfusion, in a healthcare system with no intensive care unit. So you're just being a little bit more careful, basically, if you are in an institution with without a children's ICU. Shock requires high dose catecholamines. It talks about adding vasopressin. We're also now seeing use of vasopressin now earlier in this patient group, so consider that. Now, if you have an issue of, despite the fact that you're given the volume, despite giving high levels of inotropes, perhaps you've started vasopressin as well, but there is hyperperfusion and there's cardiac dysfunction. In this scenario, you would consider using inodilators. And consider early sending the patient to, even if you have an ICU in your institution, but let's say you don't have ECMO facility, then you need to consider ECMO as a rescue therapy early, and so you need to move the patient to the facility, or if you have ECMO in the facility, you need to warn the ECMO team that your patient is likely to need ECMO and to have a potential ECMO bed on standby. So we've just gone through and we've spoken about the guidelines. I think they're an excellent set of guidelines, and I really like this quick guide. So this should give you an idea of the so we've spoken about the guidelines. Excellent piece of guidelines. So now I've just completed a discussion on the guidelines, and I think this is an excellent piece of work. I think if you look through the paper, you can see they've done comparisons between the 2020 guideline and the 2026 guideline, and I think that's also very, very interesting as well. If you've got any more questions you'd like me to address, please do mention that in the comments below, so we can look into those in terms of the management of sepsis. Please do subscribe, and I will keep you updating on aspects of sepsis, pediatric sepsis and otherwise. So thanks, and if you've got any comments about sepsis, septic shock in children and otherwise, please put in a comment below and we'll see if we can address those. Please do subscribe as well, so we can keep you updated on what's going on. And we'll move on to our next video, which will talk about other aspects of sepsis. Thank you very much. So, we've just spoken about the guideline. Excellent piece of work. Thanks to colleagues internationally who've put a lot of time into this. And I think this gives a nice direction going forward. If you've got any comments on this video, comments about what else you would like to see, please put your comments below and we'll see what we can do. And then we'll move on to our next video. So that's the end of the talk. So we've just finished describing this excellent guideline. If you've got any comments or any queries and questions, please put them below, and we'll see you in the next video.